Okay, well, turning our attention to our first talk, so precision emergency medicine through AI. So it's been 2.5 years since the explosion of ChatGPT with the matching explosion in projects and research. And we looked through a lot of projects and asked our speakers to share 3 projects with dispo changing potential, what we're always looking for in the emergency room. So I'm joined by Dr. Dev Dash, Dr. Joshua Joseph, and Dr. Maya Yadom. So we'll start with Dr. Dev Dash. So Dr. Dev Dash is a clinical assistant professor in the Department of Emergency Medicine at Stanford. Prior to that, he received his master's in public health from Harvard University and clinical informatics fellowship here at Stanford. His research interests focus on computer vision and natural language processing. Take it away, Dr. Dash.
Great to see everybody in this call. Start the slide. Perfect. Thank you, Fran, for the really kind intro. It's so nice to see a diverse audience on this call. And I'm really excited to introduce this high yield project Andy Chu and I have been working on in partnership with AstraZeneca. We're both emergency medicine faculty here at Stanford, and we're singularly focused on projects that solve high stakes problems and drive value. And one such project that we're focusing on using AI methods is detecting high-risk patients who may benefit from early intervention. Specifically, we're looking at patients who are anticoagulated or in common parlance on blood thinners. Increasingly, these drugs are used to manage stroke risk and treating blood clots. Unfortunately, there can be some really severe side effects. So if you're in a trauma or you have a gastrointestinal hemorrhage and you're on these medications, these drugs can hamper your ability to control bleeding. And patients can have really life-threatening consequences as a result. They can get admitted to the ICU, get on blood pressures, get blood transfusions, and sometimes even die, unfortunately. Now, every physician here has treated patients who have suffered from these anticoagulation side effects. Sometimes the bleeding is obvious, like in a severe car accident with head trauma. Now, in these critical moments, we quickly scan the head, identify the hemorrhage, administer a specific reversal agent to counteract this anticoagulation medication. But sometimes, and many times actually, patients look like this: elderly, gaunt, sunken eyes, uncomfortable appearing, with a gaze that just looks past you. And during a really busy shift, it can be easy to overlook a patient with real subtle signs of ongoing life-threatening hemorrhage. And we can do better as a society and as a specialty. Thankfully for our patients, life-threatening bleeds are not common. Turns out the fact that these events are not common is actually a big problem for training AI models. Having a very low incidence of anticoagulation related bleeding episodes, it's good for patients and society, but it's not good for the thousands of examples AI models need to learn. Now, this paradox highlights a crucial point where clinical decision support and the advancement of AI in healthcare intersect, and innovative solutions are needed to bridge this gap here. These handwritten numbers that you're seeing on the slide here are actually from the MNIST database. It's basically your hello world of AI and machine learning. Every budding data scientist and enthusiast cuts their teeth on this data set. It's where the journey begins, with 7,000 labeled examples for each digit. Now, I remember starting with this very data set a few years back when I was starting to teach myself to code. And there's something incredibly satisfying about it. As you progress, writing longer and more intricate algorithms, progressing through linear regression, logistic regression, eventually making your way to convolutional neural networks and maybe transformer models, you watch your model's accuracy climb. It's kind of like a digital pat on the back, and it's a tangible measure of your growing skills. It creates a really powerful positive feedback loop that keeps you motivated and eager to learn. Now, we're in the era of publicly available large language models where you can just ask GPT or Claude to write code for you. And gone are the days of fretting over missing semicolons or commas. And the democratization of these methods is truly remarkable. With just 6 lines of code written by GPT, you can download this entire numerically handwritten data set, create a train test split, and train a complex vision model. It's that accessible. And you can even have GPT modify your code for you for your own personal hardware. So maybe you're using an Apple GPU or cloud infrastructure. You just tell it what your underlying hardware is, and it can redo your code so it works efficiently on your available hardware. That being said, we still face this original challenge that these models often require thousands of examples to learn effectively. And this reality is particularly disheartening for clinicians. When we're dealing with life-threatening anticoagulation-related bleeding, finding thousands of examples is not just difficult, it's often impossible. And the scarcity of this data presents a huge hurdle in applying powerful AI techniques to our clinical workflows. I want to take a step back and engage in a little thought experiment. Now, these four images that you see here represent different ways in which we perceive and understand the world around us. Physicians in the crowd, you'll instantly recognize the top left as shingles. Now, if you think back, how many cases did you need to see before you were comfortable identifying the next case of shingle? Probably not more than 10 or 20, right? And in our everyday experiences, how many cups of coffee did you need to smell before that aroma became unmistakable? Or how many avocados did you need to squeeze before you knew when the next ripe avocado was in your hand? And let's not forget some of these painful learning experiences. How many sunburns did you need to have before you could distinguish that specific discomfort from other types of injuries? In each case, our human brains needed surprisingly few examples to learn and generalize because we're incredibly efficient at pattern recognition. And mastering these skills often requires very minimal exposure. And this is kind of the reality we face in medicine as well. In every healthcare organization for this specific project, there are probably only a few hundred cases of life-threatening bleeding that have received reversal. The number of examples is quite minimal. But there's a really good, interesting silver lining to this cloud. The complexity and capability of AI models are growing at an astonishing rate. And it's happening right before our very eyes in very public and noticeable ways. If you've ever gone through an SFO airport, you get inundated with ads about Claude and news about the AI race. It's Anthropic versus OpenAI. It's Google versus Meta. Each one of these tech companies is releasing a new model. Almost feels like every couple of weeks, and it's practically impossible to escape the buzz. So I feel like this rapid advancement in AI technology isn't just hype, it represents real progress. And it's offering hope that we might soon bridge the gap between our limited medical data and the robust models we need to make meaningful advances in patient care. You know, unlike the Dr. Dash from a couple of years ago, maybe we don't need thousands of examples anymore to train up an AI model. Maybe our models are now sufficiently complex that we can feed it a few hundred examples and they can learn what a high risk patient looks like. And we can hopefully build that as part of a clinical workflow. And so we want to do data cohort discovery in a data efficient manner. And once we do that, we can move on to standardizing our prescribing practices. And we definitely cannot wait for thousands of examples to accrue within our health system. That's not realistic for our field and for many other fields that we intersect with as well. Instead, we're moving and innovating to make the most of the data that we have right here, so we can ensure high quality care downstream. And of course, these models are complex and they can handle much larger feature sets. And so we're feeding these models vast patient data, ensuring that they can explain their decisions. This approach ensures comprehensive analysis along with some transparency, which is needed at the bedside. Like physicians want to know if an AI model thinks a certain way, what's the underlying thought behind it? And I think that explainability can be really helpful. And of course, we'll continue to iterate on more complex models to continually accrue data and assess accuracy and revamp as necessary. And so looking forward to kind of engaging with our teams at AstraZeneca and Dr. Andy Chu on this project. And it's a super exciting time with these increasingly complex AI models that are available to us.
Thank you, Dr. Dash. That was really interesting. Um, so we're gonna move on and do questions at the end. So next, I would like to introduce Dr. Joshua Joseph. So Joshua Joseph is an associate professor of emergency medicine and a clinical informaticist at Brigham and Women's Hospital at Harvard Medical School. He is the medical director for data analytics for the Mass General Brigham Emergency Medicine Network. His research examines the intersection of patient throughput, clinical decision making, and quality through the lens of machine learning techniques.
All right, thank you for that introduction. So I'm going to go straight into it and actually build off of the last speaker. I'm going to tell you, it may not feel this way in Palo Alto, but I can tell you from New England, winter is coming. And I don't just mean that from a temperature point. I mean that in terms of how we address a lot of the AI innovations that are near and dear to our hearts. It's not just because I'm skeptical. It's not just because history tends to present in cycles. But I think we are about to crash off of a big period of AI optimism. That having been said, I think for the clinical environment, not all is lost. So I think there are, even though I think ChatGPT and other LLMs are very cool, I think there are a lot of major issues with their use for real-time clinical applications. I think, there was this incredible optimism even within the last 2 years about how well ChatGPT and other models engage in clinical reasoning. I don't think that that was actually quite as significant as some people make it out to be. Not only because I think that the accuracy reported in some of these studies was maybe less impressive than the headlines would seem to imply, but because I think that many of the examples that have been used are actually quite contrived when we talk about clinical reasoning. Again, one of the things that we look forward to in most of our clinical decision-making systems is that they are very consistent, and that has been a significant issue for large language model outputs. I think that, again, what large language models do in terms of pattern matching and pattern recognition is really impressive, but the very fact that many commonly used commercial and publicly available LLMs can significantly change their outputs with even just very small changes in the text of the input, regardless of the actual content or logical content of the prompt inputs, is a serious issue that we have to be willing to countenance. And on a deeper philosophical level, I don't think that LLMs engage in clinical reasoning in the ways that we maybe expect them to. And this is a serious issue if we're asking clinicians, frontline clinicians, emergency physicians, to trust these systems when they don't necessarily provide consistent results. I think as well, even though you may show a study that shows an LLM may provide a really accurate use on a test data set, there are really substantial issues in deploying these systems in the wild. I know most of the US seems to be on Epic nowadays, and they're pushing their cloud compute platform, but the implementation difficulties alone make, I think, a lot of these systems very cool, but unlikely to gain wide adoption. And even when we're not using them for clinical decision support in terms of diagnosis, there are other real issues with even stuff like text summarization using LLMs. There's a really great study recently from Dr. El Haddad's group over at Columbia, where they were looking at LLMs to summarize medical records. Again, as an emergency physician, one of the most useful things I can find in a patient chart is like a really well-written discharge summary, where I can see patients' past medical history summarized in a very succinct format and find data points that are relevant to me, especially if they come in with similar complaints to what brought them into the emergency department to begin with the last time around. They used open source LLMs, and we're just kind of working on using this text summarization to generate kind of much more succinct discharge summaries. What they found was that despite fairly clear instructions and very well collected data, they tend to generate very incomplete and occasionally unfaithful summaries. In terms of actually why I think this project is interesting is they actually kind of flipped the task a bit. They tried to limit without going into the paper in depth, and I really recommend you check it out, They basically worked on distilling a much smaller model to just find the salient entities. And I think that this is at least much closer to the approach we might want from one of these models. Find me the information that's relevant to me as an emergency physician. But again, even a small hallucination in a task like data summarization could be disastrous in the emergency department. If you have a septic patient and the LLM is telling you this patient's last echocardiogram had an EF of 65%, and they either didn't have an echocardiogram or this is just a hallucination, it's going to cause real harms. And I think, again, we're still dealing with a bit of a paradigm issue in that we tend to look at how well ChatGPT and other such models work, and we fall into a similar trap in terms of looking at them as having comprehensive or coherent reasoning. What I think, really should emphasize that there's actually a lot that we can still gain from the old tried and true models. Again, there's one research pipeline that guides most of our clinical decision support within emergency medicine. It's basically the system that underlies the derivation of the Ottawa ankle rule, the Canadian head and neck rules, the PERC rule, Heart score. These all actually had a really similar research pipeline, which basically looks like you take every conceivable variable that you think could potentially be used to predict this condition, and you throw it at a wall and see what sticks. More mathematically speaking, you take a large collection of potentially relevant clinical variables, you perform a multivariate regression, you get a couple good candidate variables, and then you either use a logistic regression or similar tool to actually find out which of those candidate variables can help you create a clinical decision score. Now, again, I think that there's still a lot of boring AI work and ML work that can be done that can really enhance where we are at our current state in emergency medicine. In particular, I think there's still a lot we can get out of basic neural nets, random forests, and other slightly more complex regression type tools. Again, from our group, this is now ancient history back in the heyday of 2021, but even looking at ICU-bound patients at triage based on very limited information such as vital signs and a chief complaint, comparing an emergency department's current paradigm of nursing triage, using the data just from the nursing triage assessments alone, we're getting around 50% AUC. And even bumping up to those very basic tools using just those data points, vital signs, chief complaints, and initial one-line nursing text descriptions, we're able to use neural networks to get pretty darn good accuracy, well beyond what I think is considered standard. And again, this is back in the ancient days of 2021. And it turns out that even when you go beyond regressions, when you're no longer looking at just a point score, using stuff like Shapley values to help illustrate how your model is reasoning can significantly enhance the amount of trust that clinicians have in the system. Again, when that information is explained, even if it's in a proportional kind of way, clinicians are willing to use it to supplement their judgment. So I think what we actually need, there's a lot of work that LLMs can productively do in terms of enhancing clinical decision support within emergency medicine. It's just a matter of where we apply them. So rather than thinking of these models as doing the work of clinical judgment, we should actually think of them as repurposing machinery of ground level NLP work. It's in the same sort of way where if you do vision tasks, we basically, for many models, are starting with these kind of foundational models that have already been trained using convex neural nets and large databases. Almost nobody is using Laplacian matrices anymore for their vision tasks. They're starting with these models, and we should basically approach the NLP tasks in the same way. We should be using these as the starting point for many of these tasks. Because a lot of the time, what we really need help with is in helping to get our clinical variables together. Again, the groundwork, the spaghetti we're collecting for our research here. There's tons of unstructured data within medical records that could be very useful to these models. Like, does the patient have tenderness on exam? If most of your clinicians use one of these structured templates, that's great. You can usually get a very binary variable about whether abdominal tenderness was present from here. It gets harder when people are using free text. And at my institution, a lot of the attendings will use templates for many portions of their chart, but not for the physical exam. I'm pretty sure there's no tenderness in this chart. As you start getting more abbreviations, it gets harder and harder to abstract. And looking at a particular attending's plain text description, again, a lot of our attendings see patients with residents or PAs. There's no field that they put abdominal pain. You have to imply it somewhere from their MDM. It's really hard to figure out. Now, you multiply this over 60,000 ED visits, and you have a real problem. Maybe if you have 75% of clinicians using the structured template, you can just pull those. You're still left with 15,000 charts to manually review just for tenderness. And then there might be material elsewhere in the chart that contradicts the initial exam. Maybe in their MDM, they say, on repeat exam, there's no tenderness, but there's no second physical exam documented. So how do we do this? For a lot of departments and a lot of research projects, somebody just manually reviews the charts. Trying a research assistant, a lot of times we found in our lab, you might be looking at better than chance accuracy a lot of the time. Assigning a resident, while they're usually better readers of the charts, they're not exactly available much of the time. A lot of times this really devolves upon the PI and other attending's colleagues to perform a chart review, and that's just not a good use of resources, even if it's more accurate. So again, you could use traditional techniques, but again, you will find that things get very clunky once you start leaving very well-structured data. So ultimately, what you can do is you can go beyond this. You can actually use LLMs to do your chart review, to extract many of these things you might otherwise use in an NLP-based review, but with far less hand tuning. It's basically a matter of cutting down from hours for a bespoke set of rules to, days to hours. You can use structured data as exemplars. And you can use your clinician reviewers to efficiently relabel examples and use them for task-specific outputs to avoid many of the other issues that come up. Again, this is attractive because a lot of the machinery for using these LLMs for these specific tasks, rather than trying to do your reasoning, you can do with a very lightweight model. You can distill smaller models, and it really is time you're investing forward. So for our real-life data set, using an open source model, we got pretty good first pass accuracy finding tenderness without any fine tuning, but you can turn this around very quickly with just a few exemplars. Again, the issues that come up with this are way beyond the time I have to go through. This is a really great review paper, but I think this actually may be the killer app for using these models in emergency medicine research.
Thank you, Dr. Joseph. That was super helpful. I like the winter is coming analogy. Last but not least, we'll turn it over to Dr. Yiadom. So Dr. Maya Yiadom is an associate professor of emergency medicine at Stanford. She is the principal investigator for the Stanford Emergency Care Health Research Data Coordinating Center. Her research focuses on the applications of evidence-based medicine to optimize clinical operations to target patient pathophysiology for time-sensitive conditions and is supported by the National Institute of Health. Dr. Yiadom.
Good morning. Thank you for that introduction, Fran. It's an honor to follow Dr. Dash and also Dr. Joseph, who had the opportunity to work here at Stanford with Dr. Dash and have crossed paths in both the informatics and clinical operations spaces nationally with Dr. Joseph. And there have been a couple of take-homes that have come up over the course of the morning that are very related to the work that I will present today. And really the idea of having digital health and AI-enabled ways to solve problems in emergency medicine is a really thoughtful discovery process of where we need it. And understanding what we need it to do is probably even more important than the mathematics behind it. A lot of the way that my group has approached the use of AI has been how much math is enough math to solve the problem. And to what degree can a mathematical approach be integrated into the particular place within the care workflow? We have two arms to the work that we do. And on the one side, we really focus on clinical operations problems that need solving, and then spend a lot of time thinking about how we can use AI in order to address it. So what I'll talk about today is really how we've been able to think about the journey. And I say journey because we've thought about the idea of deploying AI in the clinical environment as a process and not an event. And really using AI to improve, in this case, heart attack screening performance, to illustrate a few of the concepts that have come up that we have developed mathematically and also from a research methods perspective around how you deploy in the clinical environment that have led to some discoveries along the way. First, I'll mention that we've really taken this approach that we don't turn on any functionality until we have tested it and we've learned to understand it, and have learned through that journey that we've had to create ways to mitigate some of the challenges and the negative effects before we move on to the next step. So I'll illustrate some of that for you here. And so the clinical care problem that we're addressing with this particular example is really STEMI screening to diagnosis. And as many in this audience are familiar with, the goal is to diagnose within 10 minutes. Screening occurs upon arrival in the ED before a physician generally knows a patient is in the department. And patients that are suspected of potentially having a heart attack or STEMI in particular are expected to jump queue to get a diagnostic test, an ECG. A judgment is made by the staff who are upfront, and it requires prediction of risk that's done in many ways historically and in a very blunt fashion that can be highly variable when it's implemented by individuals. Um, what we have done in order to understand exactly how this works is we've actually prototyped the problem by understanding the clinical workflow. And in doing so, have looked from before the emergency department, how patients come into us, and what information they are coming primed to provide when they walk in the door can change the course of how well we're prepared to get them where they need to be. How they enter the emergency department, depending on how they initiated the need for care, also has some biases that could be favorable or less favorable to them in terms of, do they have an advocate presenting additional information when they walk in around why they're in the emergency department that day. And when they're engaging in the intake process, we are both gathering information to start both their physical visit, but also the electronic existence they have that tracks along with their visit. But there's a risk stratification that's built into those early steps of encountering our care environment. And what we've seen is that when that screening happens effectively, patients can be put in a pathway that gets them to treatment quite quickly. And in the case of STEMI, being identified as needing an early ECG gets them that ECG is taken right to a physician. That physician has an opportunity to interpret it and then decide if it looks concerning to make a diagnosis, if it indeed is a STEMI, and to activate care in a timely fashion. However, that screening that happens at that early step risk stratification encounter is not efficient and the quality is not high. They can become a false negative and they can wait for physician evaluation. And in many of our emergency departments, the amount of time that they will wait will exceed the window that we have to deliver an effective intervention. And what we've seen is that this area of screening, as is the case for many conditions in emergency medicine, but most definitely for heart attacks and STEMI in particular, is an opportunity to introduce high levels of quality where we can develop predictive models of various types of mathematical backgrounds that can exceed what humans are capable of doing at this particular step. And that's really important because quality of screening at this step directly influences the timeliness of diagnosis and also the timeliness of treatment. And we've had decades of research that show that the timeliness of treatment is directly related to mortality rates as well as incident heart failure in those who are able to survive. And so what we've seen is that we have a gap in screening where what we currently are doing, we've done surveys across the country in high performing and low performing emergency departments. We've looked at the variety of different ways that we do intake and triage across the United States and really found in general it's oversimplified for be able to have reliable use by the staff when we know that the way patients present is highly complicated. And when done by physicians is done quite well, but physicians are not involved in this step of the emergency department journey. And that what we see when we look at performance across sites is that we end up having low sensitivity where even though we practice to try and capture 100% of patients, we actually capture far less. And in a national study that we have performed, we saw that despite the medians, which was what we track nationally being within 10 minutes at 7 minutes, that the percent of patients who are above target is at about 37%. When you look at who's in that tail, who's above that 37% window, we find that there's a disparity signal as well. So not only is there a quality signal, but there's a disparity signal. And we use this problem as the foundation for how to then build a model that could address this problem and outperform our current human performance. And in doing so, found the right location in terms of the patient's journey to insert artificial intelligence. In addition, we're able to find an area where there was a scope of data available and a window of time for data availability to work with as some of the clinical practice parameters around which we were building. Just to show you some of our early results, what you can see on this slide, and I'll call your attention to the gray line, is the fact that the gray line is human performance. And we were concerned about two things. One is that it's pretty far away from 100%, and two is that there was variation across sociodemographic groups. If you look on the left underneath the total area, you can see the gray line. The gray dot here represents where we were overall in terms of performance. What we initially did is created a base model, and as you can see, the base model performed better than human performance, but when we looked across sociodemographic groups, and we're looking at equity in performance across these groups, we noticed that it actually made predictions in two demographic groups worse, or actually three. One with our Black patients, our Native American Pacific Islander patients, and also Hispanic and Latino patients. We found that even though the performance overall was better, that this was not sufficient for implementation because it was actually worsening disparities despite improving performance in enough patients to increase the overall population performance. We retooled that with an iteration of the model that we refer to as our diversity sensitive model, where you can see that's the dark green line. We're able to improve performance for everyone, but you can see the swings in the data between the populations that perform best for and worse for, they actually widened over human performance. So we made everybody better, but we made the people who were doing well before even better, far better than the people who were not having the best benefit. So we exacerbated disparities even though we improved performance. And then what we noticed was that our assumption was that the algorithm, the AI model, was going to be operating independently and instead of humans. And we really took the approach that Dr. Halamkat spoke to earlier of if we introduce this into the workflow in a way that augments human performance, what would happen? And that's what you see in the blue lines across the top. Not only overall do we have far better performance, but you can see the base model and our diversity sensitive model both outperformed humans and the model acting alone. We did not have what we would hope for, which was to really take the swings in the data across those two demographic groups out. And what we learned through this is although we were very happy with the performance overall and within subgroups, we really did want to zero out this variation. And it required us to understand the model was really taking a lot of the practices from historical data that we were training it on. And it was doing exactly what it was told to do, which is to copy and paste, but do it better than we had before, better in terms of prediction. But there were variations in how it understood those predictions to fall within demographic groups. We actually had to create ancillary coding, additional coding, post-processing information to give to the model before application to take those swings out of the data. And that really gave us the opportunity to introduce this additional post-processing. And with that, we were able to take the swings in, as you can see, get these results that are on the screen here for various levels of sensitivity. And so for us, this journey really highlighted the idea that even though we could improve performance with an algorithm, that being able to step through it provided us opportunities to learn about some negative consequences that might have happened if we just deployed. In doing this with real-time data, but in silent mode, allowed us to correct this before actually turning it on for patient use. And so I'll also highlight the idea of there are trade-offs when you're looking for better testing, higher sensitivity, frequency of testing reduction. I know we'd all love to have less ECGs flying around the emergency department. And we often use this as a way to this particular slide that I'm sharing with you here to show how we can get higher sensitivity than we might currently be achieving in an emergency department. But it can come with a trade-off for ECGs in terms of the number of ECGs that are being performed. And we're working on a third level of modeling where we're seeking to reduce or increase the precision of the algorithm in order to reduce the number of ECGs that has to be done in order to achieve the best sensitivity. So this has been a very interesting methodologic journey for how to solve clinical operations problems in order to achieve a clinical outcome for our patients, while also improving the amount of testing that needs to be done, the precision of the testing that needs to be done to make sure that the right patients get the care that they need as early as possible to have the best outcome possible. Thank you.
Thank you so much for that. Thank you all for three really interesting presentations. I have a lot of questions, and we also have some questions from the audience. So I'll start with the questions from the audience. So I believe the first question is directed towards Dr. Dash. So, Dr. Dash, for your project, what are the biggest challenges you faced in integrating AI into clinical workflow, and how did you address them to ensure clinician adoption?
Yeah, thank you for that question. One of the biggest challenges that we still continually face every day when trying to integrate AI solutions into the clinical workstream is incentive alignment when trying to build teams. So when we kind of walk across the street, go to our Department of Computer Science, walk into Gates and try to find a collaborator, we often find that the problems that healthcare deals with are maybe a little too simplistic for the cutting edge models that are being developed across the street. And so we want to be mindful of our collaborators and we want to advance their careers as well as help patients and create a win-win scenario for everybody. And sometimes it just happens to be that we need simplistic methods that drive value and maybe the most complex frontier model is not the answer. And that won't get you into a computer science kind of national conference because they're kind of focused on the methods. So finding that project that aligns a high impact, a potential high impact solution with something that a clinician is interested in and understands it, with something that a computer scientist or data scientist and something that furthers their career can be one of the biggest challenges that I think every institution across the country is facing right now when building these AI teams.
Thank you. Dr. Joseph, I had a question, which is, I hear you on kind of on the potential pitfalls of using LLMs, and specifically sounds like relying on them solely. What do you think are some opportunities for them and to mitigate some of the concerns you mentioned? I think you mentioned, I think, a lot of people in our community have definitely are on this of the stance that no one is looking for these things to replace the clinician, is more of an augmenting. And so with that in mind, what are some roles that you think that these could play? And could it be through having more physician input or other methods? Would you mind talking about that?
Yeah, so I think that's a great question. I think there are a number of ways that people will approach this. I think one is potentially restricting the range of outputs that LLMs can provide. Again, I think that a lot of what's really cool about LLMs is, you ask ChatGPT, write me a limerick about X, and then you ask it again, and you get often a completely different output. And that is from the standpoint of creating a product that's very human-like and very interesting. That's great. And I think that in some of the applications which we might use LLMs for instance, like following up with patients, having, kind of available conversational agents with patients, that stuff is great. And again, while we still probably may need to tune those models a lot, having a lot of that variability is a very good thing. But I think that in terms of when we are talking about clinical decision support, we really have to talk about a very restricted range of responses. And one of, I think, the benefits for using them for something like summarization, if we're using them in the clinical, specifically in the real-time clinical environment, will be basically methods kind of like the Shapley models, which I showed before, where we want the AI to, or we want the LLM to actually show me the evidence you're using. Give me a hyperlink or give me an actual copy paste item saying, you say this patient had a recent echo. Here's the link in the chart. Here it is. I'm just kind of reassembling information that's there. For where I'm using LLMs, for text summarization, where we're looking at, 60,000 charts, is it the worst thing in the world if the AI hallucinates a bit and there's a confabulation in 1% to 2% of the charts? Probably not, because nobody's individual care is really being impacted. And again, even with your multiple attending clinicians who are doing summarization or doing this chart review, Inter-rater reliability, there's still a couple percentage points easily of disagreement in a lot of charts. And at the end of the day, if I can get an AI that's within a couple percentage points of accuracy, that's still, I think, an accurate representation of the data set as a whole. So again, I think that those may be some of the killer applications. They're boring in a sense. They're not the sexy, I'm talking to the Oracle and it's giving me an answer. But that is where we can use these to leverage a lot of time saved, a lot of money saved.
I like that. Yes, getting ChatGPT cite its work, if you will, both on the evidence, research evidence, but the patient's individual studies.
Yeah, Dr. Joseph actually brings up a really good point about like the variability in responses. I will say that the current large language models are all built on a transformer architecture. And if you had to push a transformer into giving you believable content or truthful content, it will almost always prioritize believability over truthfulness. As in, producing content that fits linguistic pattern is more important to a transformer architecture than producing content that is factual and verified. And I think that's one of the biggest problems that we have in rolling out a transformer-based model for high-risk applications, think clinical decision support, widely. Like I would be very uncomfortable rolling this out widely to an audience that maybe doesn't understand the underlying model.
That makes sense.
And just to highlight off of that, I think vision, if we're looking for where a lot of the big pickups are going to be, image analysis, signal transduction, these are areas where you look at ConvNets, you look at most of the sort of reasoning that's going on in these systems, it's much more transparent. And I think that, again, while I think there are going to be a lot of cool applications here, the biggest impacts to our individual clinical care may be more like, the initial review of the chest X-ray, and basically the AI saying, I'm concerned about this area, that may be an infiltrate or something like, I'm concerned about this ST segment. I'm bringing it to your attention as a clinician. And that's the augmentation that we're going to be seeing. Because I think there's just so much better reproducibility in terms of those models.
Yeah, absolutely. And it kind of goes back to the point of its role as an augmentation as opposed to a replacement. Dr. Yiadom, I really liked how you talked about your work and not only kind of the obviously just the changing role it played, but also the addressing the hopefully improving in disparity. For me and many of others, I think we hope that in some ways these technical tools can be trained to have, less bias and things like that. But obviously that wasn't the case in the initial run. I appreciate you talked about kind of your model, how it was improved to improve kind of sensitivity that I know we can't get into it in the time that we have here very deeply, but at a high level, I think that's such an important effort. Would you mind talking a little bit about how you address that?
Yeah, no, happy to, because I feel like it's been far more complicated than we anticipated. One, the idea you're training models to pick up on logic that's in data sets of prior patterns of care. We haven't always had it right in those data sets. And recognizing that you can structure the thinking that you want to replicate, but then have to check the thinking and in some ways modify how the model then applies it for future care delivery. It is no small feat, and it's really taken experts from different fields to figure out the right way to do that journey. So on the one hand, we have wanted to improve performance, and I think using models, just modeling in general, introduces a consistency. It allows us to use predictors much more effectively and in ways that humans might not be able to collect, and we achieve that goal. But the second step, we actually saw that the model was exacerbating disparities and that this is a general trend within modeling, that it picks up on frequency characteristics and risk characteristics and doesn't pick up on patterns of lack of access to care in order to have the data, in order to make good predictions, despite somebody physically being in there with an active emergency condition. And because of that, needing to one, teach the model to act differently in different populations, and then how it will oftentimes calculate low risk or high risk in certain populations consistently, is then something you need to take back and sort of teach the model how to then act. And that step between the prediction that a model might make or an action the model might determine and the action it actually will introduce into the care environment is another step to the application of models that I think that we found to be interesting. And the disparity signal on how to introduce algorithmic equity into not just predictive modeling has been a parallel journey that's been a step that if we weren't looking, we wouldn't have seen it and would have been very satisfied with the improved performance. But because we had committed very, very early to ensure that we were closing the equity gap, we did look and found a whole body of work that was, I think, probably 3 to 5 years worth of experimentation to get it right, and are in the process really of turning that into something that other teams can use in order to close disparities gaps as well.
Thank you for that. Yeah, it'd be interesting to hear that in detail and kind of help other people replicate that effort because it's so important. Okay, I want to make sure we get to more of the audience questions. So I think this is for everyone. Are there any LLMs currently in development for medicine like MedGPT instead of relying on ChatGPT?
Yes, is the short answer. I can't speak to what individual private companies are doing, although I can assure you that there are some out there doing this. But even if you go and use a utility like Olama, which if you got a laptop made in the last, I don't know, 4 years or so, you can probably go online and get now. You can go to Hugging Face or one of the other major repositories, and you can see people who have publicly posted some of these open source LLMs, and which have been specifically fine-tuned for a number of medical recognition and reasoning tasks. Yeah, I don't have a slide with me with a chart for comparison, but you can basically Google this right now, and you'll see people post kind of what these models' performance is on these various tasks. Again, these tasks are also being continually updated and demonstrated. So this is an area of active development too in terms of evaluation of these models. But yeah, these models are in development. You can go probably grab one right now in the span of this talk.
Yeah, that's good. We should have a toolkit after that we'll send out after this. Okay, a question for Dr. Yiadom. Fascinating insights on using AI for heart attack screening. What specific AI techniques or models have you found to be the most effective in enhancing screening accuracy, and how do you address potential biases in these models?
Yeah, no, this is a really important question. I sort of alluded to some of our discovery in this space when I mentioned that how much math is too much math. On the one end of the spectrum, you can use really simple models and things that, are extensions that we learned in high school, y equals mx plus b, and come up with models that you can implement that are very explainable. People understand the inputs, they get the outputs when you explain it to them because it mimics how we were taught to make decisions as physicians. On the other end of the spectrum, we have things like neural networks and complex decision trees and machine learning methodologies that it's very difficult to explain how the inputs result in the output. And one of the things we've seen is that the compute load can sometimes outstrip the benefit of implementing the model on the far end of the spectrum. And on the other end of the spectrum, the variability and the quality of the prediction can also be a challenge. What we've seen is in general, having a model is an improvement over humans. And so we've taken a minimal viable product approach, but have a whole line of research to really march through levels of complexity. And I do think that this is a question that is important to address when you're starting, as in our case, from the clinical scenario and figuring out which kind of modeling is best for this particular scenario. Because you don't often need the most complex model that, as Dr. Dash was saying, will be most exciting to our computer science colleagues. It often cannot overcome the barrier of practice change when you bring it into the hospital setting. And sometimes starting out with something very, very simple, but outperforming humans as the threshold can get you into using modeling. And then you can do this experimental journey with, if you go from simple logistic regression to multiple logistic regression to lasso techniques to, and then go through the whole discovery of different levels of machine learning complexity. And then you can also experiment with the size of your data sets. What we have seen, again, is that any model is better than humans. If programmed and trained very well, it can outperform humans. And we've done the journey of implementation with simple models and then have increased the performance of our models by taking many more complex techniques. The bias factor goes up as you use different kinds of models, though. As we use more complex models, and learning about the bias with each technique is a journey we're doing now to learn how to mitigate each type while balancing the benefits of the effort to mitigate, and figuring out what we can program within our electronic health records is another step, because some of the mitigation techniques just can't be implemented. We don't have the capacity for that just yet. So it's a non-answer for the answer, but to say that there are benefits for prediction, there are downsides for the compute load as you get more complex models, and the biases that come up with each type are a journey in and of themselves. And to date, we found that the biases with the more complex models actually are more challenging, that haven't been worth the additional improvement in prediction. So erring on the simple side has actually been a more acceptable approach for moving into clinical practice implementation.
I like how our bar in these years have moved. Before a while, 5 years ago, artificial intelligence was like, oh, maybe it's like a 3.5 or 3.5-year-old level. Now our bar is as long as surpasses the average clinician. So I like that, how that's been raised. Okay, one thing we wanted that was asked. So outside of your individual projects that you guys are working on right now, which obviously has a ton of potential for each of them, when you guys were kind of looking around in these fields and the possible applications, what are some other killer apps outside of your own that you also considered, that you also feel like have potential? And if you can comment on uh, some of the limitations that might, in addition to the ones that have potential, but also some of the main limitations that we need to overcome to address some of those that you guys came across during your own exploration. Oh, that's for everyone.
I will say that is the billion-dollar question here. Like, what is the killer app that will kind of revolutionize medicine? Maybe it's $100 billion question.
Perfect. I'll take notes and then know what stocks to buy after.
Yeah. So I think one of the biggest problems that we face, and I think actually every industry that intersects with data scientists and like AI methods faces, is pretty much all problems are local, and you need to do an extreme deep dive into every single facet of your particular problem. Otherwise, it will look like your entire AI model has, plus clinical workflow, has failed, even if the model was great to begin with. And Dr. Yiadom has talked about kind of the deep dive she's done into her diversity and equity space, into the STEMI model. And we've looked at all the issues regarding ChatGPT. Sometimes these democratized models, like ones coming out of Anthropic and OpenAI, we don't know what they're trained on. And so it's hard to tell when they'll fail. Even with models that we train ourselves on our own data from scratch, we have a vague understanding of where those might fail. When we're using commercially available models, the failure rates are unknown and hard to predict. And so kind of building killer apps around this is like very challenging. I will make a plug for, there are very few applications out there that intersects across the entire patient realm. So for example, an app or a service that not only speaks to the patients that live around here in the Bay Area or the peninsula, but also can speak to every other patient that intersects with the health system and helps them navigate through the system. I haven't seen anything out there that is helpful for our entire gamut of patients. And we don't want to be building tools that are relevant for Stanford and Harvard and Hopkins. We want to build tools that are important for the entire population, even global populations. And so I haven't seen anything there. So that's my small plug.
Yeah, I tend to share Dr. Dash's pessimism, perhaps, but enthusiastically optimistic pessimism, that there is no killer app, there is no one solution for everyone, and there is some degree of local validation that always has to be done for all the reasons I think we've all talked about here. And that we've seen this in other spaces where we brought innovation to clinical medicine. And we have to remember to do that in the space of AI as well, that to some degree there's this tailoring for the right use case and the right environment and the right conditions. And when those parameters change, the AI needs to change too. And so to some degree, there might be an out of the box component, but they're always, and I say 80/20 just because it's a nice, balance, but the idea that 80% can be brought to you, 20% needs to be tailored for you. And in order to really get precision, particularly when it's expected to do the right thing for every patient it touches.
Yeah, I hate to sound like I'm just echoing everybody else here, but I do think this is, again, a case where we're going to need to develop consensus in terms of some of these models. Before the Society for Academic Emergency Medicine conference every year, there's a consensus conference. Before, I think, somebody can correct me if I'm wrong, I think there's similar mechanisms with ACEP and with many other medical societies. I think the kind of future state of this may be that we have people from a lot of centers collaborating on models that are probably pretty simple at first, but are, not overfit in a way that they're really, really good for one medical center and kind of inappropriate for another. What we may see in some, not too long away from now future is that we share as a larger group a vanilla model that may be pretty simple. And basically it's pooled and it works on the data from Harvard and Stanford and Hopkins, but also works on the data from Cook County and LA County and somewhere non-coastal, because that's immediately where my mind jumps to. And then, once every year that model is released, it's the chest pain model or it's the, stroke prediction model or something like that. Then, the individual sites run wild with it. Yeah, let's drill down and make it super specific to our patient population and get, from 90% accuracy to 95%. And it's okay that the Stanford flavor of that model doesn't really go out into the wild and get used at other centers, because next year, we're going to redo the vanilla model again. We'll all raise the tide for every medical center so that we're now starting with the 92% model, and we'll kind of innovate from there. And I think that sort of an approach has the benefit that not only could it be done on a really large patient pool, but we can explicitly try and avoid some of the hyperlocal issues that come up when you have maybe a large portion of your patient population that is really well plugged in, and suddenly we're trying to fit this model or use this model on patients that don't have good representation in those data sets, so that we avoid some of the more specific equity concerns that these models are at risk of exacerbating if we don't account for them.
And Dr. Joseph, just to add briefly to your comment, because I just think the way that you phrased that was brilliant. One of the things that we've seen in addition to the idea that there's always that local component is shift and drift is real. And even in very stable patient populations with stable clinical practice, that we have seen some amazing shift and drift that we've yet to be able to understand. Even when we've used theoretical calibration techniques that we would hope would erase the shift and drift, if we have tried to do this in simulation going back in time, it just has not done it. And it's actually had us wonder if rederiving models over time is as important as recalibrating models over time or calibrating to local scenarios. And so I think the quality maintenance part of this, the quality assurance part of how these perform, monitoring over time is highly critical. The idea that we turn these on and then give it trust that it's doing the same thing every day over time is, I do think we need to be skeptical when we're trying to augment what we are hoping to do on a daily basis.
Thank you for sharing all three of those inputs. And I think, as you touched upon, I mean, this panel, we are represented by East and West Coast. One of the things that I'm really excited about our community here at STEMIX today is there's a lot of people coming from the community emergency departments across the country. And I can say, because I looking at the registrants, let's say a third to a half are physicians. For those who are not, you probably may or may not know that community medicine emergency departments actually account for a much larger percentage. And so despite the fact that these works are coming out of the academic medicine, we excited to have our community medicine partners and encourage you to ask representative questions throughout the day. So we're nearing the top of the hour. Thank you all so much for presenting your work today. We're so grateful for your time. Thank you so much for presenting 3 such different works and perspectives.